and talk a little bit about the anatomy. So we've got a cutaway view of someone's skull. So imagine this is the bone, and peeled away the scalp and the hair and all that. And then there's this a thick layer called the dura mater, which is a leathery-like covering. It literally looks kind of like a thin piece of leather when you get in there. Inside that leathery covering are some vessels, typically veins that run through that. So you can see the sagittal sinus here. So you've got a leaflet of this dura that comes down like this, and another leaflet that goes across the top, and that triangular space that it leaves behind is what the sagittal sinus is, which is the big draining vein in the brain. Then, adherent to the inside of the dura, you have the arachnoid, and there's another layer of arachnoid that is adherent to the pia of the brain, so it's almost like a double layer, and has very fine little strands that will connect it, and so those are, that space in between is filled with fluid, called spinal fluid, or CSF, and we call that the subarachnoid space because it's within the arachnoid, and then adherent to the brain itself is the pia. And the pia is absolutely stuck to the brain. You can't take the pia off the brain without damaging it. You can take the dura and you can take the arachnoid off the brain. It just sort of lifts right off, unless you have something really weird going on, like some kind of inflammatory process or something like that. So you can get different kinds of hemorrhages in the brain. So you can imagine you can get an epidural, which would occur between the skull and the dura. And that typically occurs in what scenario, Amy?
Trauma.
And what has to happen to get a epidural? You're not taking
I know, I
questions
forgot.
today. I'll get to you later.
No, you won't. You do not. It's like a contra coup type thing where the head goes forward and the brain goes back and it pulls away from the line.
Oh, not close. Anybody else? Who knows what you two can't talk? When do you get epidural hematomas? What's the pathology?
Temporal bone fracture, tear of the middle meningeal artery.
Right, so the middle meningeal artery is an arterial bleed, and there's little arteries that supply the blood supply to the dura itself. It's a fairly vascular structure. So the middle meningeal artery comes off of the branch from the maxillary, which is a branch off of the carotid, punctures a small hole at the base of the skull, and then enters through that hole to supply the dura, and the artery actually runs within the dura itself. So when you get a fracture, it will tear that artery. When the bone, typically the temporal bone fractures, that bone will get torn. This is a blackboard, isn't it?
Mm-hmm.
We have
I don't know
chalk.
if there's chalk.
It's my kingdom for a piece of chalk.
So you can't have, can you not have an epidural hematoma then in like your occipital lobes?
You can have it almost anywhere in the brain, but the most common place is the temporal lobe. That's the most common place. So, can you see if we don't turn on the lights here?
You turn on the lights to draw that. Draw.
Oh, we can see it.
Man and white.
I can see it.
So the dura, which I'll sort of draw like in here, and this is the bone of the skull, will actually have a little recess in it. Have any of you ever seen an actual human skull? You looked on the inside, you can kind of see where the arteries run, right? And there's a channel like this, so the artery in cross-section will indent into the bone a little bit, and you can see those channels on the inner surface or the inner table of the skull. And you can imagine if you break that, you can tear that artery, and that artery bleeds in such a way that it actually will cause this situation. The artery is stuck to the dura, and it's spurting blood out, and it's pulling the dura away from the inner table of the skull. So we're going to see a lot of those when we start seeing trauma here. Usually it's car accidents, bar fight where someone takes a baseball bat and hits you on the side of the head, or something like that. Pull cue, good one, pull cues do it. And there's a classic story that goes with epidural hematomas.
You have a loss of consciousness and then regain of consciousness.
And then?
And then you lose consciousness
That's
again
right.
and blow a pupil.
Exactly. exactly. That's the classic story for an epidural hematoma.
Wasn't that Natasha Richardson?
Yes.
That was her deal too, right?
Who's
She,
Natasha Richardson?
the one that she died at, she was at a skiing accident.
She's
Oh,
an
yeah.
actress.
She's married to Liam, is it
Yes.
Liam Neeson?
Yeah.
She played the mom on Freaky Friday.
Oh, yes! Whatever.
No, she did the same thing, she hit her
Cause
head,
she, and like refused, like I'm fine, refused
they found her dead at a
medical
hotel
treatment,
room.
and then, you know, she was
Right,
unresponsive, yeah,
Yeah.
okay, sorry.
And generally speaking, for trauma, how do those patients tend to do? If you had to say, if you had to pick a head injury to have, is an epidural a good one to pick or a bad one to pick?
Bad. Yeah, well.
It's actually a good one to pick. Most of the time, if you get to the time before they herniate and die, they do quite well. Right? They typically return to their level of functioning before, as long as you get to them before they actually herniate. Okay. So that's an epidural hematoma.
I have another question. So, because I feel like when I read about them, a lot of times it's in a younger population who cannot handle any kind of compression of their brain. But what about in the 80-year-old, 90-year-old patient with some atrophy? Do they still?
So you're
Have
very,
some problem.
very rarely going to see an epidural in a 90-year-old. And the reason is because as we get older, the dura becomes a lot more adherent to the inner table of the skull. It almost literally, sometimes when I do a craniotomy on older people, there is no real dura left. It's incorporated into the bone, and when I lift it off, the dura comes right with the bone. You can't physically, it's just not possible to peel it off. So you just don't see that in older people. You see other things, like our next hemorrhage, we also see subdurals, because what happens there, see this picture shows it really nice. So you got these veins, so the veins drain from the brain, they have these little bridging veins that pass through the arachnoid and into little channels that run inside the dura that eventually make it to the sagittal sinus, right? And these things are real vulnerable right in that spot. So right between where those bridging veins cross from the arachnoid into the dura itself. Here it shows it as a little bit of a white line, but in reality there's no real space there. Okay, it's a potential space. But if you get tearing of these veins right here, they bleed right into that subdural space. So the plane between the dura and the arachnoid is called the subdural space. And so what's the story with subdurals? As opposed to epidurals, like how might they present? What situations do you see them in?
A old person that fell and hit their head.
And you can see them in younger people with really high velocity injuries, but it's less common, just like epidurals are less common in older people, subdurals are less common in young people, because when we're younger, our brains are really swollen relative to our skull, right? You have sort of, and this potential space is really, really tight, okay? Whereas the reverse is true for their epidural space. Their dura easily peels away from the skull, so it's easier for them to get a subdural. Whereas in the older person, this space, because the brain begins to shrink and pull away from the intertable skull, that space is a lot easier to create in an older person than it is in a younger person. So you'll just see a different age range. Outcomes compared to epidurals? Worse? Yes. Okay.
Why?
More of the brain is being affected by it, number one. Number two, just the age range you tend to see it in. And number three, it tends to be happening because of severe movement of the brain. What the mechanism is, the brain moves within the skull, causing the tearing of the artery. So that you had to have a certain amount of G-force or abnormal motion of the brain to cause that problem. Make sense? Okay.
I'm prone to have, once you have one, you're prone to have many more. Your brain just doesn't, yes.
Doesn't like to re-expand. And there's that the whole chronic, I'm talking more like about traumatic subdural. There's the other issue of the chronic subdurals. Chronic subdurals, patients tend to do usually pretty well. You get to them in a reasonable amount of time. And those, you get a little tiny tear, gets a little bit of blood, And it's not that they're still actively bleeding months later that causes them to have this chronic subdural. What happens is that fluid, which is hypertonic, as the red cells that got into that space begin to break down, they release all those proteins, they release all their electrolytes, and it sits there, and it's a relatively avascular space. So this plane between the dura and here, there isn't a lot of circulation, so there's not a good way for the body to resorb all that stuff. But it's a high osmotic fluid, and so then it tends to draw more fluid into it through osmosis, and it tends to grow. And then as it grows, it tends to tear little tiny veins that are right next to it and leak a little more blood in, and it releases its electrolytes and proteins and draws more osmotic fluid in. So they sort of grow slowly by little bits and pieces to the point where it's like the straw that broke the camel's back, and they start having symptoms. But they can be there for months before, from a remote injury before the patient ever becomes symptomatic. Now we get to the subarachnoid space. So the subarachnoid space we talked about is this true space, and it's filled with spinal fluid. And what they're not showing you on this picture, but what also runs besides these little veins is the arteries that course over the surface of the brain run in this exact plane. So if you get some arterial bleeding, it tends to track along the subarachnoid space, right? We can also get subarachnoid blood from trauma, right? We can also get what they call subarachnoid blood from, they call it after someone has a stroke, and you do a CT scan on them 5 days later after their stroke while they're on aspirin, and they go, oh, the patient had a subarachnoid hemorrhage. Not really, but they call it that because it looks like it. Right? What we're seeing there in the subarachnoid space, so if you look at, is there an eraser? I bet there is. I'm a needy kind of guy. Here, this will do. So epidural, you look at a scan, will look like this, all right? And what's happening there is the dura, which tends to be tightly adherent to the skull, but down here forming this high pressure bleeding from the artery, tends to force it in, and it looks like a lens. So it's tightly adherent here, and the pressure's pushing it in, and it's a lens-shaped thing, okay? Meaning it's got, a shape like that on both sides, all right? The subdural, it's gonna look a little different. Subdural, this is the falx in the middle, and this is the center of the brain. The subdurals will form like this, okay? Pushing the brain over. And they'll track over a large area, because once you start get this plane between the arachnoid and the dura, it just follows the entire skull until you get to the falx or some other layer of dura that it can't track along. It can even track, this picture doesn't really do it justice, but you can even track underneath the temporal lobe. You can get a tentorial subdural, where blood's tracking along the tentorium as well, all right? And then the subarachnoid blood will tend to take the shape of the arachnoid space around it. So you'll see blood sort of interdigitating in all these little spaces, because that's where the arachnoid space is. So between the gyri and the sulci of the brain, that's what makes up the arachnoid space, and that's where the blood tends to go. Now, we can get several different causes for subarachnoid hemorrhage. So, Lauren, what's a good cause for subarachnoid hemorrhage?
Aneurysm.
Okay, so a blister or aneurysm forms on one of the arteries, because it's and the arteries are in the subarachnoid space. It ruptures, starts bleeding, right? So a good cause for subarachnoid. What's another cause for subarachnoid hemorrhage?
Trauma.
You get some from trauma, from arterial damage, but what is actually most traumatic subarachnoid hemorrhage? It's really not blood in the subarachnoid space. It's actually blood that forms along the subkeel margin from contusion. It's bruising, it's petechial hemorrhage. Now, it'll look like subarachnoid hemorrhage because it'll follow all the gyri and sulci, right? Especially in a younger person, and it'll just track right along it, and the radiologist can't tell the difference, right? Whether it's in the subarachnoid space or the subpial space. Has the same look, but the mechanism is different, right? So, what's another good cause for subarachnoid hemorrhage?
AVM.
Yeah, good cause. So a vascular malformation where you have a tangle of blood vessels, and those vessels are meeting in the subarachnoid space. What other kind of hemorrhages can be caused by an AVM? Holly?
Intraparenchymal.
And very good, because the AVMs not only go into the subarachnoid space, but they go into the parenchyma itself. So depending on which part of the AVM cut loose, it could be intraparenchymal bleeding, it could be in the subarachnoid space, and also go into the Holly?
Ventricle.
Ventricle. That's very good. Thank you, Kim.
I said it before she did. I did, and that's all, no more.
All right.
So the subarachnoid hemorrhages they encompass more, literally anything underneath
Right.
that arachnoid.
So, right, exactly. So, so one of the most common diagnoses you'll see in the stroke category is going to be subarachnoid hemorrhage, and the vast majority of them are going to be little traumatic subarachnoid hemorrhages. You're going to see this on every 80-year-old that falls down and bumps their head. You're going to see it called on 20-year-olds who are involved in a motorcycle accident. And what they're really seeing is contusion, following that, it's that subpial bleeding. And the same thing with somebody who's had a stroke 5 days ago, and now you put them on Plavix, and that tissue dies, right? So the capillaries start leaking, and they leak blood. And where do they leak? They leak along that peel interface, and so it looks like subarachnoid hemorrhage, but it's really not subarachnoid.
Right.
But it tends to be called, when you start looking at diagnosis codes of subarachnoid hemorrhage, you'd be amazed at how many people get discharged with the diagnosis of subarachnoid hemorrhage and how few of them actually have something like an aneurysm.
Right, exactly.
Is it correct to say that if it doesn't necessarily originate in the subarachnoid space, but yet you have these small traumatic or intraparenchymal or the contusion that you just spoke about, that is seep the right word, or that it spreads into that if it doesn't?
I don't think those patients really aren't seeping into the subarachnoid space.
It just
for the most part. I mean, there are probably some cases where you do get arterial damage from major trauma that has true subarachnoid blood in the subarachnoid space. But you know, the patient who has a stroke and is scanned 5 days later while on Plavix, the patient who, the 80-year-old who falls down, gets a contusion, those really aren't subarachnoid blood. It never gets into the subarachnoid space. You did a spinal tap on them, you wouldn't find any red cells.
Xanthochromia.
Right, well,
Am I wrong
Thank you.
to say that your basal ganglia hemorrhage
Mhm.
that ruptures into the ventricles,
Mhm.
and then if I did a scan on them a couple days later, they may look like a subarachnoid because that blood is in the ventricles that then is circulating the subarachnoid? Or am I wrong?
Usually not. Usually that blood will be, you could get a little bit of blood spill over into the subarachnoid space, right? It is possible to get a little bit of spillover from that. And why does that happen? Right? Because most of those hemorrhages are coming from the little lenticular striates that come off the middle cerebral artery. And these arteries come off as perforators straight up into the basal ganglia. And the hemorrhage occurs here, but some of it can track along the artery back into the subarachnoid space. Some of it will go and become bloody. If there's enough ventricular drainage, some of that blood may circulate out around. That would probably be the exception. It wouldn't quite look the same. Most of that blood that when you see in the ventricle, it solidifies, and then by the time it's breaking down and recirculating the CSF, it's not bright on CT scan. Right? That's kind of why it won't look the same on a CT. You'll have bloody CSF, but it won't look bright on a CT scan because it's the wrong age blood. You did bring up a point about a different kind of hemorrhage, a mechanism where someone's head gets sloshed around. What kind of hemorrhage is that?
You talking about the coup?
Coup, what's going on there? Contusion. They get contusions. They can have that sort of subarachnoid-like appearance, but they also get diffuse axonal injury. So they're carrying a whole bunch of little blood vessels scattered throughout. If you do an MRI scan, what's it going to look like on an MRI scan? So somebody who has diffuse axonal injury, they might have a teeny little tiny, frontal lobe. So the story goes, they tripped. Something slipped, they fell backwards, hit the back of their head, and they have a tiny little hemorrhage on the front, just a tiny little spot, and they look like crap. They look terrible. And you do an MRI scan, because they're not waking up and they look terrible, and what do you see on the MRI scan?
Do you see nothing?
You want to agree with her?
Diffuse petechial hemorrhaging?
Very good. So it looked like pepper flakes. Looks like someone ground pepper all over their brain, little tiny hemorrhages, petechial hemorrhages you won't pick up on a CT scan, but the MRI scan will be very sensitive.
And is that within, is that right away, or is it like within 24 hours? It takes a little time.
Depends on
for
what,
that
it takes
to
a little
develop.
time it'll take a little time for it to show up.
Okay.
For bonus points, anyone want to tell me what sequence you want to look at on an MRI scan? Anybody want to tell me, are there more than one sequence or two sequences that you can do on an MRI scan?
Flare, T1, T2,
Yep.
diffusion,
Yes.
diffusion weighted.
Yep.
Is that all of them?
GRE, the great one. That's the one that's most sensitive for blood. So if you're looking for blood, you want to tell the radiologist, make sure you do a GRE sequence. Gradient echo is what GRE stands for. There's that one is the one that, they look like little black blossoms. The blood really stands out, the black spot on those sequences.
Is it gray or white matter? The diffuse axonal. I'm sorry, what was the question? Gray or white matter injury?
Very good. Which is denser, Amy? Gray matter or white matter?
Dr. Mullen said she's a spinal cancer and you got it.
Why do you think that?
Because of the myelin sheaths on there.
What's myelin made out of?
Protein.
What's myelin made out of?
I don't know.
I would make it U2.
What's myelin made out of?
Yeah, I would make them U2s because I specifically asked.
Ollie, what's myelin made out
I'm
of?
thinking.
It's lipids. It's mostly lipids. Okay. What's in your gray matter? What's in your gray matter? Indira, what lives in your gray matter?
I don't know.
That's right. Very good. It's your neurons. This is part of you that thinks. The neurons live in your gray matter. Part of you don't know.
Okay.
So neurons, being cells, are full of water, right? They're full of proteins and water. And the myelin, the white matter, is axons surrounded by basically coils and coils of lipids. So which is denser? Very good. Why? Because it's water, and lipids are and fat floats, right? So water is denser, gray matter is denser, and so you now have a differential, right? So when you look at the brain, what are the basal ganglia? Brainstem and basal ganglia. Is that white matter or gray matter?
Gray.
Great, very good. And then you have the centrum semiovale, which is made of white. And then you have the outer cortex, made of
Outer cortex is white?
gray.
Gray?
Right.
All right.
Very outer cortex of your brain is gray.
Okay.
Right?
Okay.
So there you are, you're driving along in your sports car, trying to get to the lecture, and you're doing 70 miles an hour in a 30 zone, and you hit a lamppost, and your brain comes to a sudden stop. So your skull comes to a sudden stop. Your skull hits the steering column and can't move an inch. What continues to happen? The brain will continue to rotate, but the inner portion, which is your brainstem and basal ganglia, relatively dense, white matter relatively light, and then the outer cortex, very dense and very heavy relative to all that stuff, keeps rotating, right? And it tears the bridging axons between your basal ganglia and brainstem to the outer cortex, and that's what diffuse axonal injury is.
Especially corpus callosum, usually lights up pretty good.
Okay, so let's get back to our topic. This is just another view of the CSF spaces that can form, that can be in the araxon space itself. So this is showing, we're going to do an anatomy quiz. So since Indira came in late, what's that?
Pawns.
No.
Here, wait.
Where is the, can you, wait, let me put my glasses on. That is the pituitary?
Very good, pituitary. And what connects the pituitary to the brain?
Stop.
Stalk, also known as the infundibulum. All right. And then what's this area right here?
Yeah, midbrain.
Midbrain, very good. And below the midbrain is the
Pons.
pons,
Followed by the medulla.
medulla, and then the spinal cord. Very good. Okay.
So when they say infundibulum in those MRIs, they mean that? So when they say it's not an aneurysm, it's an infundibulum, they mean that?
Oh, no, very good. That's another one of those things where they're using the same word on totally two different meanings.
Well, they
depending on the
should do
context.
Why would they do that?
Why would they do that? That's one of the crazy things about English. We do that all the time.
Oh, I thought it was neurosurgeons came up with that.
No. So that's very good. So let's go back over this. So we called the pituitary stalk carries the other name as an infundibulum, right? The infundibulum pituitary of the stalk. What is an infundibulum on an artery? Now that you mentioned it, what is that?
It is not an aneurysm.
It is not an aneurysm. Very good. Well, what is it?
I think it looks like an aneurysm if you get an angio.
Okay, very good. All right, so I'll give you partial credit for that one.
Thank you.
I'll give you partial credit.
All right.
All right, so we're going to talk about how aneurysms form, right? So we got to talk about the anatomy of an artery. So if you're cutting an artery in cross section, time for beer?
Yes. She's going to take a shot.
It's only one.
What do you think?
So if you cut an artery in cross section, the innermost layer is called the intima, and that's one cell layer thick. And the job of the intima is to keep blood from sticking to it, right? So it's a very slippery, smooth, and it's got proteins on it that inhibit clot activation and so on. Then there's a layer of strong fibers. Then there's a layer of muscle around it, right? And there's sort of multiple concentric layers of muscle around an artery. Okay. Now, if you looked at you stripped away the muscle, and you look at the artery, what those strong fibers kind of look like a fishnet stocking that wrap around the artery. Okay.
Is that
These-
connected?
Hmm?
Is that the connected tissue?
It's a connective tissue, it's a type of collagen, and those fibers are what actually give it its strength, not the muscle itself. The job of the muscle is to control how much blood gets to your brain at any given time. So you're sitting there, you just ate a big meal, and you're watching some stupid sitcom. You don't need a lot of blood going to your brain. You need to digest your food. And roughly, how much blood flow? What percent of your blood flow goes to your head?
20?
20, about 20% of your blood flow goes. That's a lot. Thinking about it's only, less than 5% of your body weight is accounting for 20% of your blood flow. So if you don't need a lot of blood flow going to your head, you need to, digest the big meal. It's going to squeeze shut, and less blood's going to get to your head, more blood will go to your gut, right? Now you're sitting there and you're concentrating, pay your taxes, you need more blood to go to your brain, it'll dilate up and allow more blood flow in there, okay? So that's the purpose of the muscle. But these fibers are the one that actually provide tensile strength in the artery. Now, if you put on a pair of fishnet stockings, and you can imagine you get it up over your leg, a relatively smooth cylinder, it's easy to distribute those fibers in a way that it provides good, strong reinforcement of the artery. Now, if we make a branch off the artery, and now you start drawing in these fibers, so you can imagine right at the branch point, imagine trying to pull a fishnet stocking up your leg if you had your arm sticking out, you could have parts where you might get gaps in that formation of those fibers, and typically it occurs at the crotch where vessels meet, okay? And you get this weak spot, and over time, it dilates out and forms an aneurysm. That's the classic story of how an aneurysm forms. It's a classic aneurysm in the brain. An infundibulum is a little different in that in there, what you're seeing is every so often, if you have a branch coming off, the artery comes up, and they never are completely straight, they can loop and bend and twist and stuff like that, but they come off nice and cleanly from the artery, right? Nice sharp demarcation. That's the majority of the time. But every so often, they will come off like this. They'll have a broad base, like that. And you can see, now you've got something that looks kind of like an aneurysm right there, but there's an artery coming straight out of the dome. And actually, this part is normal vessel, it just has an abnormal shape to it. And sometimes on an angiogram, it's very difficult to tell whether it's an aneurysm or an infundibulum. So every so often, we do get fooled. We think it's an aneurysm, go on and explore it, turns out to be an infundibulum.
But is that infundibulum, that's not weak, like an aneurysm, because it's got that lining. And you don't see vessels coming out of the dome of an aneurysm.
Right, not supposed to.
Okay.
Now, I will say it's never 100% of the time.
Okay.
Every so often we do find little branches coming out, and just like any artery can be leaked, you could get a weak area on an infundibulum.
But it's not typical.
Not typical.
Okay.
Right. Okay. So that's how aneurysms form.
Is there any way to differentiate it with any of the studies?
Well, typically they're small. They're typically 2-3 millimeters in size, rarely 4 or above. You try and with the new 3D ones, you try and look for the artery coming out of the dome, and there's certain places where they're typical to see them, like on the PCOM is a common place to get an infundibulum. So there's certain things we can look at and say, yeah, that's probably an infundibulum versus an aneurysm. But sometimes it can be tough to be 100% certain.
Yeah. It's usually kind of wide mouth like that.
Mm-hmm.
They tend to be.
They typically have that classic wide mouth to a little point with an artery coming out of the point. All right. So now we're gonna reserve our talk towards the non-traumatic subarachnoid hemorrhage. Now we're going to ignore all the 80-year-olds that fall off their head and all the motorcycle accidents that have contusions and not really subarachnoid hemorrhage anyway. Estimated to be about 30,000 cases per year in the United States, which roughly accounts for 5% of all strokes. And remember that a subarachnoid hemorrhage is a stroke because, Amy? Well, there's hemorrhagic strokes can be hemorrhagic and ischemic, like there's both kinds. So unlike some of our esteemed colleagues in the ER, we can have hemorrhagic strokes and not just ischemic strokes. All right, mortality rate overall, when you look at some of the studies, it can be very high. When people ask me, I typically say that about half the patients never make it to the hospital from an aneurysmal subarachnoid hemorrhage. They just die on the spot. Of those that survive, about a third will come out okay. About a third will go on to die despite our best efforts, and the remaining third will have long-lasting consequences from the event. About when we see truly non-traumatic subarachnoid hemorrhage, 85–90% of the time is due to an aneurysm. There's about probably about a 5 to 10% incidence of we don't know. But the remaining small percentage in there is probably from AVMs. AVMs are way more rare than aneurysms. So we talked about ruptured aneurysm, we talked about the non-aneurysm, we'll talk about what perimesencephalic means. There are other rare things that can cause it, so arterial dissections, AV fistulas, rarely septic aneurysms, sometimes with severe high blood pressure and cocaine abuse, as we sometimes see it. Pituitary apoplexy, but that's really more, the pituitary blew up and just spilled over. Any questions about what those conditions might be? Anybody? Those rare conditions?
Oh, it says rate. What, you know what pituitary apoplexy?
Yeah, that's.
Pituitary apoplexy. All right, who wants to educate us about pituitary apoplexy? Not you.
Everybody looks at me.
Is it bleeding into the pituitary?
Very good.
Okay.
Right. An apoplectic event is a sudden catastrophic event. Right? You can say, Dr. Gorge was apoplectic on the phone with me the other night when, you heard we gave the patient mannitol. So, yeah.
But that's rare, isn't it? I mean,
It's
I don't
very
know if
rare.
I've, okay.
It's very rare. And they typically present with severe headache. They're typically blind. Right? And dear, why would they be blind?
Because the pituitary is close to the optic nerve.
Very good. So, big hemorrhage and it tends to take out the optic chiasm, makes them blind. And they'll have what can look like subarachnoid or a big clot in the base of their skull where the pituitary is supposed to be.
Do we know what causes that catastrophic event?
Most of the time it's due to some kind of a tumor that
Okay.
infarcts and dies.
Okay.
That's what we think is the majority of cases. So subarachnoid hemorrhage. So what do the patients typically present with?
Erica, you tell us, will you
We're gonna turn to an expert. What do they feel when someone has a subarachnoid hemorrhage?
Just a sudden onset of the worst headache of your life that you just can't explain.
And you say it was right neck.
Yep, and my neck was stiff and I had nausea and vomiting.
You had the neck stiffness right away
Mm-hmm.
with the headache?
Not right away, I would say within like 10 minutes, I
Okay.
started realizing that I couldn't move my neck.
So if someone says, well, how am I gonna know, I get headaches all the time, but I'm not having subarachnoid hemorrhages, what would you tell us?
I do suffer headaches all the time, and I did think that it was just like a headache. I was like, maybe I've never had a migraine, and I thought I've had a migraine. This is what a migraine feels like, but I don't know. Just
It was vastly different than what you
It was,
typically
yeah, it was,
experience.
and it was the onset just being so quick.
Yeah.
Normally with migraine, like you get some kind of aura or something like, you're gonna get one, but this was just like quick.
And so those are very common. Luckily, you didn't lose consciousness. A lot of patients lose consciousness with this. Occasionally, seizures can occur. Can happen. There was a brief mention there of cranial nerve palsies. What's the most common cranial nerve palsy with ruptured aneurysm? Yvonne?
7.
7? Anybody want to agree with her? 6? 5, 4, 3, 2, 1.
It's 3.
3. What's 3? Which nerve?
Pupil?
What's the name of the nerve?
No.
Help her out, Amy. What's the name of the third nerve?
Is it the oculomotor?
Very good. Good. So what does the oculomotor nerve do? What does it supply? So if you have a third nerve palsy, right? Someone comes in, they got the worst headache of their life,
You have a blown pupil.
right? Because,
There's a constriction of your pupil.
right, is that sympathetic or parasympathetic?
Sympathetic.
You sure?
No. I'm just giving you an answer.
Okay. Anybody want to help her with
To
that?
constrict it would be parasympathetic, because sympathetic is gonna dilate in your fight or flight.
Right, so in the setting of where you lose the third nerve, are you losing your sympathetic or parasympathetic nucleus? You're losing your parasympathetic because the sympathetic take over and cause it to dilate.
Yes.
Right? Okay, so what else happens besides their pupils are dilated?
Ptosis.
Ptosis, which means what in English?
Oh, the drooping of the eyelid.
Eyelid. And what else do you have? Oculomotor. Motor. What's the motor function of the third nerve?
The
And deer knows.
Like the lateral movement of the, like they can't see this ways. Like to the right, if you tell them to see to the right, they can't do that, they can't see.
With the left eye or the right eye?
No.
So Yvonne, help her out. What nerves control the motion of the eye?
3, 4, 6, is that right? It isn't.
3, 4, 6, very good.
Oh,
Okay.
I'm sure I backed into that.
So what do we call so we can tell the oculomotor nerve is 3, right? And we're gonna go to and it's the most complicated of them. So we're gonna say, what are the other 2? So what's 4? What do we call 4? Trochlear.
Trochlear.
Good, very good. And what does the trochlear nerve do?
Lateral move.
What is the trochlear? It's the superior oblique, is what it
Very
is.
good. Superior oblique. So and so if you pull your superior oblique, it makes you have trouble looking down and in.
Yeah.
Right. And what's the 6th nerve? Abducens. And what does the abducens muscle do?
Like
That
everything
makes
else.
sense. Is that a sentence? What does the abducens do?
I'm gonna say lateral again.
It abducts the eye, right? So that makes it move out. So if you have the 3rd nerve palsy, right, what you're gonna have trouble doing? Looking in. Right? Won't be able to look in. So
Prefer the term down and out.
So that's the most common, so the 3rd nerve is the most common cranial nerve. And why is the 3rd nerve the most common cranial neuropathy with a ruptured aneurysm? Because it runs right next to one of the most common aneurysms we see, which is the posterior communicating, PCOMs. So the PCOM artery, posterior communicating artery, runs right next to the 3rd nerve. They're virtually touching. And so if you get an aneurysm of that, aneurysm will often, the jet of blood will often damage the nerve. Sometimes if they don't have a sudden, so somebody presents to the ER, right, with a sudden 3rd nerve palsy, what could it be? Could be an aneurysm, even though they don't have a headache, and even though there's no blood on the CT scan, right?
It's not big enough, it's pushing.
Pushing on it, right. Now, if they call you and say, hey, I've got a sudden 3rd nerve palsy, but their pupil's small, are you worried that it's an aneurysm?
No.
Why not?
I feel like I remember that Dr. Garcia was teaching me that because of the parasympathetic is, I feel like on the outside,
Mhm.
and that would be where the pressure is, so then.
Right, so when they call you that somebody has a pupillary sparing 3rd nerve palsy, what typically causes it in that situation? Diabetes. All right, and the mechanism there, so if you did a cross-section of the nerve, so if you looked at the center of the nerve, so first of all, you're right, that the parasympathetic fibers are on the very outside of the nerve. And when you look at the vascular anatomy of the nerve, if you actually physically looked at a nerve, you would see there's little tiny blood vessels that run on the outer surface, right? Little tiny ones that are on the outer surface. And they supply the outer portion of the nerve. There's often also a little central artery in the center of the nerve that'll supply this part. And in diabetics, it's that tiny little artery on the center of the nerve that tends to infarct off, and they get all of this dead, they lose all the motor function, but they spare the parasympathetics on the outside. Goodness. All right? So that's a pupillary. All right. Turn off, which switch was it?
Well, she said that.
It's okay, you can turn it.
It might just
It looks
confirm.
good.
Not that one? No, there we go. All right, so that's better. So this is a nice classic picture of a CAT scan of a subarachnoid hemorrhage. So what lobe is this?
Left frontal.
Which side?
Left.
Left, right? Everything's always backwards, so left frontal, right frontal. What lobe is this? Right, very good. What's that little black thing right there?
That's just a.
Close, but not quite. Those are your temporal horns of your lateral ventricles, okay? And usually you don't see them, right? They're not usually visible. So that's an early sign of hydrocephalus. Is that common in subarachnoid hemorrhage? You get hydrocephalus? Yes, it is. Good. What's this little black thing right here?
Fourth ventricle.
Fourth ventricle. And what structure is this?
Occipital.
Cerebellum.
Cerebellum. Okay. Here's Indira's favorite structure. What's that? Pons. Yeah, pons and pons. Okay. So this white stuff doesn't belong there. CSF should be black on a non-contrasted CT. And so acute blood, a couple hours to a couple days old, should be bright white. So that's all blood. You can see on this patient, kind of got a big blob of something here. So if you asked me to bet a couple bucks, I would say aneurysm could be there. All right, this is what a three-dimensional angiogram looks like. So you can see the carotid artery coming up. You got a branch, this is called the ophthalmic. Carotid continues on and branches off into a middle cerebral and the anterior cerebral. When you see this thing that looks like, kind of like, I don't know, got an ear to ear, a snout, kind of looks like a pig's head. That's actually a multi-lobed aneurysm coming off of the anterior communicating artery. And that's what it looked like on a 3D angiogram. And typically when you see, if a patient has multiple aneurysms in the brain, the one that has these little nipples on them, that's the one that most likely bled. It's probably bled from one of those spots. Yes?
You know how you said on that, well, the patient's left side, but that blob there makes you suspicious that it's an aneurysm? I see it kind of on the other side too. It looks kind of
thick.
Yeah,
It does
so
look
it's,
bigger.
but I mean, I see how what you're
Right.
pointing at looks bigger.
It does. And
But
it could be, and I don't know if this CT scan matches this angiogram, it might.
okay,
You know, and that's why we do angiograms. We don't just operate based on the CT because
It is the same patient, but I don't know how,
if it's the exact.
well, the rotation, because it's a three-dimensional rotating image. So I probably rotated to see the best look for the,
All right.
Can I ask you a quick question? On the previous picture, can you just show like the territory of like middle cerebrals and just, cause I don't have a handle on that at all.
So
Some of the bigger vessels.
middle cerebral,
Okay,
anterior cerebral,
okay,
and that'll come up in a strip over the cortex.
okay.
Posterior cerebral.
That's really rough.
It's not, it's brain surgery. All right. So, we're gonna need someone to grade these CT scans. I think Amy should grade these. Right? So, what's this one?
One.
Why?
Thin blood, no interventricular hemorrhage.
And what's this one?
Probably a 3, I don't see any interventricular hemorrhage, 6 subarachnoid.
Okay. And this one?
That's a 4. That's a 2.
Why?
There's thin subarachnoid and there's blood in the ventricles.
Very good. All right, so that's the Fisher scale. So now we're gonna go for Hunt-Hess. So, Holly knows
Easy.
Hunt-Hess.
I
Okay.
know Dr. Hunt and Hess. Do you remember them?
you knew Dr. Hunt,
I remember
you know
Dr.
Dr.
Hess.
Actually, I didn't know Dr. Hunt. I just knew his wife, but I did know Dr. Hess. Super creepy guy. Go
Yes.
ahead. What's your question?
All right. So basic scale: 1, 2, 3, 4, 5. Without looking up at the board.
Okay.
All right. What's a grade 5?
Well, that's based on symptoms, and the patient's unresponsive with massive aneurysm rupture.
All right.
So what do they look like?
Unresponsive.
Completely. Okay.
Totally
Often
unresponsive.
Usually fixed and dilated.
And maybe like close to, if not already brain dead.
Yes.
Most neurosurgeons won't touch that.
Most of them.
That's why I said most. Okay, go
So
ahead.
what is a grade 2 then?
Grade 2 is they do have a hemorrhage, they have a headache and starting to have some other symptoms along with nausea, vomiting, maybe even some pupil changes.
Gotcha. And when would you call someone a 3?
They're sleepy. All of the above, and now they're sleepy.
Holly.
Alright, so one of the bad things, what's the one thing we really are afraid of with subarachnoid hemorrhage? We're talking now aneurysmal subarachnoid hemorrhage. What's the worst thing that can happen to the patient? Rebleeding. Mortality rate's 80% if they rebleed, so it's really, really high. Other problems we talked about was hydrocephalus. I think Kim's talked ad nauseum about the catecholamine storm and all the things that can go with it. What are the things that can happen from a catecholamine storm, just to refresh us? Like, Are you getting chest pain?
It reduces the contractility of the heart muscle.
Yes, very good.
It causes the fluid to back up into the lungs.
Very good. Is that a cardiogenic thing, or is there some other mechanism going on that can cause it?
It's not cardiogenic.
Very good. All right. And then lastly, what are we fighting with for the next 2 weeks?
Cerebral basal spasm.
So we talked about the anatomy of the blood vessels, right? So we talked about that there's smooth muscle cells surrounding the arteries, and those smooth muscle cells are sensitive to all kind of both electrical and chemical stimulants. And it's the chemical stimulants that are bothering us in subarachnoid hemorrhage. And what happens is, as the blood, right, begins to break down, and it releases heme, it's the most common component that is the biggest irritant is the heme part of the red blood cells, and will cause the smooth muscle cells to contract. So you can do that experiment in the lab. You can remove an animal's cerebral vessel, put it in a petri dish, put a couple of drops of diluted heme in, and you watch the vessel actually constrict on you.
So why do they say that, that you worry more about vasospasm in an aneurysmal versus non-aneurysmal?
So what do we talk about with most non-aneurysmal subarachnoid hemorrhages? What are most of those? They're contusions, right? We talked about the 80-year-old who falls down has a little subarachnoid hemorrhage on the front. That's usually just some subpial contusion that looks like a subarachnoid hemorrhage.
Are you talking about the subarachnoid hemorrhage similar to what she said?
Yeah, but in her case, we
Perimesis
still would worry
cephalic.
about.
Right, you still do get vasospasm, and we've seen some really severe cases. Now, in general, when you talk about the true aneurysm negative subarachnoid hemorrhage, like she suffered, they tend to be a lot more mild. They tend to have less blood, and there's a correlation between the amount of blood, and it's not completely direct, but there is a correlation between the amount of blood and the degree of spasm people get. So the more blood in general, the higher the risk of spasm.
So with subarachnoid hemorrhages, you can have much larger volume of blood ruptured as opposed to the perimesencephalic. They're not typically that large.
Exactly.
Another thing too is, aneurysmal subarachnoid hemorrhages are arterial. Most perimesencephalics are mostly venous. You're talking about this high flow arterial versus a low flow venous.
I just figure blood's blood, it's blood.
It is.
It is, and it still has
when it
that
comes out
effect.
at a high pressure.
But I think there's also, I do agree with the ones that, so even if someone has a lot of blood, but they never lost consciousness and they're still a grade 1 or 2, they tend to have a lot less problem with vasospasm than someone who is even a grade, 3, but lost consciousness because they had transient high intracranial pressure. There's some mechanism that seems to occur there. Yes, Yvonne?
Just a quick question. When an aneurysm ruptures, why does it stop bleeding? And is that like an autonomic kind of shutdown?
That's a great question. Why does an aneurysm stop bleeding? All right, so you measure increase, so you measure ICP, right? And normally sitting here in the room, Yvonne, what's your ICP right now?
3.
Wow.
Right? And then, what is your mean arterial pressure right now?
75.
All right. So you're cooking along, and your ICP is 3. Aneurysm bursts. How? What happens when it hits 75? Blood can't get out anymore, right?
Oh.
But it needs a gradient to move forward. So once your intracranial pressure is equal to your mean arterial pressure, stop bleeding. Now, you've got a few seconds there while that happens before you lose consciousness. And in that few seconds, you know, what has to happen is you need to form a little plug. Fortunately, once you breach an artery, all that stuff that's in your brain and around the artery itself is very thrombogenic. And so you form a little plug of, you know, clot and fibrin and platelets, all that good stuff, right? And then your ICP comes back down, right? And if you're lucky and that plug holds, this will happen over a matter of a few moments. You say, wait a second, but your ICP went to 75, why didn't you just die right there? Well, you sit on the toilet and you're really struggling to get one out, right? Your intracranial pressure will go to 60, 70. You can do that to yourself transiently.
Or if you're lifting weights.
Or if you're lifting weights at Holly. Have you checked out the guns on this one?
I'm serious. Come and see me after, you can feel. I'll let you touch.
Now, if that plug is not formed well, like you're on Plavix or you're on Eliquis, what happens is as the pressure comes back down, right, the blood comes back out, and it keeps bleeding like this, and your ICP just eventually just stays at 75 and you're dead. So that's why an artery stops bleeding. All right, where were we? Where's the next thing? Let's talk about all that stuff. All right. Okay, so we're talking about the perimesencephalic hemorrhages. So fortunately, they're very rare. We talked about 5% of all subarachnoid hemorrhages. Fortunately, it's only about half of, or about 0.5 per 100,000 adults. So, and 95% of the cases have normal angiograms. And typically, our protocols, we do an angiogram. If that's negative, we let things cool down for a week, make sure that there wasn't something obscured by the original clot, right? So if a clot forms inside the aneurysm, particularly on a small one, blood won't get into the aneurysm, and you can miss it, but a couple days later, repeat it as the clot starts to lyse. Now you can pick up the aneurysm. We do see that from time to time, so that's why we do the repeat angiogram. If that's negative, then we're on the hunt for what else could cause this. That's why we're doing MRI scans, looking for things like AVMs and cavernous malformations. AVMs you would typically pick up on an angiogram. AV fistulas you pick up on an angiogram. Well, what vascular malformation will you not pick up on an angiogram that could potentially cause a subarachnoid hemorrhage? Kind of rare, but it happens. Cavernous angiomas. Right. And why are we doing MRIs of the cervical spine? Because of spinal AVMs. Sometimes spinal AVMs the blood will track up along the spinal cord, along the subarachnoid space around the spinal cord, communicates with that in the brain. If you have a spinal AVM, unless you're specifically looking for it on a special angiogram, you're not going to see it on a conventional 4-vessel angiogram. And that's why we do the MRIs of the C-spine. The cause, we don't really know what causes these. We think that it's just a small vein ruptured for no good reason. I wish I had a better explanation than that, but we don't. The majority of them have a benign course. They eventually do okay. Rare to have vasospasm, although we've seen patients who've needed ventriculostomies and had to go down the angio to get verapamil and balloons and all that kind of stuff. And in the vast majority of patients who have this happen to them, it seems to be a once-in-a-lifetime event. It's very rare. It's rarer than rare to get that repeat hemorrhage. The distinct pattern is that it typically only see the blood in the perimesencephalic cistern. Do we have a picture of that or no?
Go to the next one.
So the perimesencephalic cistern is the cistern right in front of the mesencephalon. You can tell me what the mesencephalon is.
Midbrain.
Midbrain, right? It's another name for the midbrain. There's a cistern of arachnoid. Remember I showed you those little trabeculae on the arachnoid? So sometimes those trabeculae can sort of create these sort of pseudo space, right? They're incomplete. It's like a partial partition, like this room, right? We can get in and out of this room through the doors, but if you put something really big in this room all of a sudden, you'd have a tough time getting it out of this room. So it's a partial partition, this room. So think about that. The blood gets sort of trapped in this area. although there should be small communications of CSF that can get in and out. But for whatever reason, the blood got stuck in just that area. And that's why we think it's a low pressure type of bleed, because normally if it's arterial, it's not gonna just be contained to one little area, it's gonna go throughout the whole area. But we do worry when we see that maybe it was just a little tiny leak from a basilar aneurysm, one of the most dangerous and difficult to treat aneurysms. So when you see that, it's one of two things. If it's a basilar aneurysm, usually the patient looks really sick. If it's a perimesencephalic, they're sitting up there talking to you and they just complain of a headache.
Do you find that the basilar type aneurysms still have that same amount of blood, or?
They can. I mean, that's usual. That would be unusual, right? But you know, tends to be a high pressure bleed. They look a lot sicker in general than the perimesencephalics do. They look like they're closer to death than the perimesencephalics.
If you see a basilar with just that little bit of blood, you need to be really cautious because they've leaked. They haven't really truly ruptured yet, and that's the ones that all of a sudden they go from.
So this is Erica's story. This is where he played the sad violins. Like,
That's Brian's song.
story.
That's Brian's
song.
Oh, there's so much to be the Running Man challenge.
Yeah.
So, talk a little bit about your presentation about the headaches. You did the floor vessel angiogram when you came in, no source.
Go back one more. Back. One again. Back.
Oh,
There you go.
yes.
And you
So
go back
Erica's,
again. He's never seen these slides until today.
Thank you, Kim. So 30-year-old female who works as a nurse here, we all know her, presented with this worst headache of her life, and it felt in the back of the head, and she described it as pulsating. Lightheaded, nausea, vomiting, and neck was stiff and sore. Why do we think the neck was so tight, stiff, and sore? Meningeal irritation, so the blood runs along the meninges and causes irritation. Over time, that blood trickles down the spine, and what do they complain of?
Low back.
Low back pain. Yeah. How comfortable, my back is killing me. All right. Sometimes we give steroids just to help with the pain. It seems to reduce the inflammation along the dirt. I tend not to like to use it unless I absolutely have to, because a lot of bad side effects from steroids. So we rated her GCS as 15. Her Hunt and Hess score was 1. We talked about the CT scan. We showed that was her actual CT scan. We called that a modified Fisher 1. So what would that make her NIH scale?
It doesn't pertain, does it?
Thank you. It doesn't pertain. It doesn't matter. You're not doing an NIH scale on this patient.
I was like, why are you asking that? That's exactly what I was like, why are you
Probably
asking
goes,
that?
"Why is she doing it?"
I'm like,
did that on
why did you
purpose
say
to
that?
you.
Okay. It was just for your benefit.
He's teasing you.
Okay. I see what it's
So that's the actual CT scan. I can't see it. Am I pointing actually at? No, I'm colorblind. I can't see the red dot.
He can't see the red
Oh, there
dot.
it is. All right. So there's the little bit of blood. You can see there's little like indentation there. That's the peduncles, right and left peduncles. There's a little interpeduncular fossa, and that's where the blood's pooling.
She had a little puffy tip of horn, just a little bit.
No, just a little bit. You know, you're right. It's definitely there.
Especially the next one up on the top right.
So
A
these
little bit of
little
a bump there.
slits right there. That's something we want. We typically see.
Where
in
is
people.
that peduncle? Is it next to that natural arm?
So the cerebral peduncles are part of the normal anatomy of the mesencephalon. And the next time I see you, I'm going to ask you what tracks run through the mesencephalon and the peduncles, because it's important to know that.
I told you to quit asking.
All of a sudden, like peduncle.
All right. So we did the 4-vessel angiogram. She was admitted to ICU for Q1-hour neurotrax. How was it being woken up every hour?
I was awesome.
Really?
No.
I would really hate that.
I understand why our patients who come up from the ICU are irritated and just want to sleep.
Terribly sleep deprived, right? It's like being on call for like 3 weekends in a row. Why did we place central lines and all these other lines? What were we doing there?
So like monitor all the hemodynamics,
Why is that important?
because we're looking to make sure they're not dry, and then they need to have plumper on the plumper side of vessels that they've got good blood flow to their brain, prevent vasospasms.
I just think it's so, while I agree we don't want to flood the patients uncontrollably, because that can introduce its own problems, but we'd never want to get behind the 8 ball, because once they get dry and in vasospasm, it's next to impossible to treat. So we want to make sure that they're caught up, if not slightly ahead on their fluids. Some people believe not only is the fluid status important, but also the kick of the heart, the index. Some surgeons out there believe that the most important number is the cardiac index. So with all this nice minimally invasive monitoring, so we don't have to put in swans anymore. Aren't you glad about that one? What else did we monitor? We did daily TCDs. What are we looking at with TCDs?
It means
What does TCD stand for? Transcranial Doppler. So it's a Doppler study, and so we're looking at a velocity, right? And can anyone tell me what number I'm particularly looking at?
the MCA mean.
All right, the what MCA mean? And why when people come to me and say, well, here's what the ACA and the PCA was, I go, I don't care. You know, give me.
Because
I have said what?
to that Doppler thingy that you
Do
stick
the
on.
Doppler thingy. Right?
It's
Exactly.
the
You
one that gets the
understood
best
that, right?
picture,
The
right?
Doppler thingy, huh?
It gets the best picture because of where its location versus the
Very
angle.
good, right.
It's actually
So-
the flow is going towards the probe.
Alright, so this is a patient's head, here's their nose, here's an eyeball. Alright, so so this is supposed to be the middle cerebrals, the anterior cerebrals, and the posterior cerebrals and pecons connecting them, right? When they put the probe on, the probe is put on either side just in front of the ear, okay? And so the angle of incidence is essentially 0, right, for the MCA. It's blood's coming straight towards the transducer. And so there's no error, because when you're measuring Doppler, you're measuring a change in signal. Is the way, how does Doppler work? It sends a little blast of sound, and it listens for the echo, right? And so it's bouncing off the red blood cells. Now, if the red blood cells are running at an angle, you have to do a mathematical correction to know what the true velocity is. And since all of our anatomy is actually fairly different, that angle between the ACA and the PCA and the transducer is next to impossible to reliably measure and guess, okay? So the only one that closely approximates a near 0 degree is the MCA. And that's why that's the number that I care about. And it's just a number, it's just looking for trends. We're not hanging our hats on the MCA. So even if someone has oh my God, they went up to 150 today, but they're sitting there drinking coffee with their legs crossed, say, hey doc, what's up? It's a lot less concerning than somebody who's, say, even 90, but I can't lift my right arm, kind of thing. So.
That's why a lot of the ACAs, you'll see them as negative, be like a negative number, and the waveforms go down, because the Doppler is here, and the blood is going away from the probe.
Right, so the angle is away, so that's a negative number.
So what is the percentage of people you've seen where the trend is going up and they actually have a problem? Because I'm trying to figure out if.
It's not great. I would say it's probably 60 to 70%. It's not in the 90, 95%. Okay, so sometimes those numbers, and I also, because I'm fairly aggressive about keeping their cardiac index up and keeping their fluids up and keeping their pressure in the higher range, I have a feeling that I'm seeing a fair number of people who do get some vasospasm. We see it on the TCDs, but they never get symptomatic, and so it's the beginning and end of it.
Because you're managing it.
Because
Yeah,
correctly.
proactively.
We're
Yeah,
staying on
yeah.
top of it versus waiting on something.
So you can have positive TCDs, and if the patient's perfect, you're not gonna run the angio.
Right.
And you have to remember, a TCD is tech dependent also. It is a tool. And if the tech does not take their time, and they don't get good waveforms or get a good look at the vessel,
Yeah.
just depends on the
Right.
tech.
Yeah. So you can have. We've had situations where you get like 4 days in a row, one tech, and you get this nice consistent number. Now on the 5th day, it's a totally new tech, and the number's like way off the
They don't make
charts.
any sense.
And then the next person comes back, the first person comes back the day after, and you get back to the exact same number. So, yeah.
Is there an aneurysm site that just the TCDs don't help you at all?
Nope.
Okay.
All right, we gave her nimodipine, but did we send you home on nimodipine?
No.
Why not?
Cause you said that the risk for vasospasm, I proved without a shadow of doubt that I didn't have an aneurysm, and my risk for vasospasm was very, very, very low.
But also more importantly, it's only indicated for aneurysmal subarachnoid hemorrhage. So it's a very expensive drug, and it probably doesn't do much, unfortunately. We give it mainly for medical legal reasons. And so in the situation where somebody doesn't have a proven aneurysmal subarachnoid, actually, what's the FDA actually say about the drug? It's grade 1 through 3, right? Grade 4s and 5s shouldn't be getting it. But
It
every
doesn't
nurse,
do anything anyway.
yeah, but every neurosurgeon gives it in 4s and 5s.
Typically, we keep it till you go home, and then we don't send you home.
So I remember for about 10 days, you had pretty significant headaches, back pain, neck stiffness. We had a tough time initially keeping you eubulemic. You kept wanting to pee everything out, but you got good kidneys. We resorted to albumin. Why do we resort to albumin over just plain water?
Cause my cells they were great with their water, so they weren't keeping anything in, so the albumin pulled the things into the cells.
Very good. Okay. All right, and did you notice an improvement with when we gave you extra fluid in terms of how you felt?
Yes.
Made a big difference, didn't it?
Mm-hmm.
So I believe this fluid therapy actually does something, you know, despite everyone saying, oh, they're just supposed to be eubulemic, don't chase the numbers. Okay.
If you give them fluid and their symptoms get better, they are having mild vasospasm, even with the TCD, and they don't have focal weakness. If you're making their symptoms better, then.
All right. I think that was it. Any questions? I think I took up way too much of your time.
It was interesting.
Who got the free subway card?
Well, I haven't passed them out yet. Is there any other questions?
Oh, geez.
Oh, I got so many questions, I can't tell you.